From the 2026 SPPM Annual Billing, Coding, and Practice Management course, this is a recording of the session Practical Opioid Prescribing in 2026 by Dr. Kenneth Candido.
For Disease Control and Prevention in Atlanta, Georgia, first came up with their iteration of what were known as the Opioid Prescribing Guidelines in 2016. Amazingly and fortuitously, there's been a slight reduction, actually up to 20% according to some studies, in the national opioid epidemic in the United States in the last years or 2 years perhaps. And while the Center for Disease Control guidelines are fallible, and that's why there was a second iteration in 2022 November of the guidelines, they may have led or contributed to this reduction. So it's very important. While practitioners were often upset with the fact that these guidelines were published and promoted, and some agencies perhaps weaponized the guidelines and took physicians to task for their prescribing, in point of fact, they have contributed to this reduction. So prescription drugs had formerly been driving the so-called opioid epidemic, but now we're far removed as being the culprit, and synthetic fentanyl, which we're all very much attuned to, very much aware of, is the culprit that's leading to the deaths of more Americans than any other drug and any other drug combination. These are the newest statistics. If you look at this slide here, these statistics were published 17 days ago on February 1st, 2026 by the Center for Disease Control. So you're not going to see anything more updated than what you see presented here today for the CDC. And I'm going to just run through a little bit to show you this graphic shows the available information for the 12-month period up till February 1st, 2026, showing about an 18.9% reduction in the percent of drug overdose deaths in this country, which is fantastic. For the last year or year and a half, we've actually dipped below the 100,000 drug-related deaths in the United States over a 12-month period. Leading up to that in 2022 and 2023, we had about 115,000 deaths per year. There are still some states which are outliers. You can see that this graphic shows that the overall United States has seen about an 18.9% reduction in drug overdose deaths. And when I say drug overdose deaths, I'm including all drugs, not just prescription opioids, of course, but things like fentanyl, heroin, cocaine, benzodiazepines. So there's been about a 19% reduction in the United States. There are still some states which are outliers, however. Look at Arizona. I included it with this large arrow here: Arizona, New Mexico, interestingly, North Dakota. Some other states have continued to see an escalation, but by and large, the country has shown a reduction in overdose deaths, which is very fortuitous. Now, in the United States, we consider that there have been 3 waves of opioid overdose deaths dating back to the late 1990s. The first wave of opioid overdose deaths, now not just all drug doses, but opioid related, started with the rise in prescription writing. So we had some culpability as physicians for initiating the first wave or the first phase. The second phase, denoted by the second arrow on this screen, shows the rise in heroin overdose deaths, which began in about 2020 or 2010, I should say, so 16 years ago. And the third rise began about 13 years ago with the influx of synthetic fentanyl, which was created in China and Mexico, which was reconstituted in laboratories and then transported across our borders. And then there was the adulteration of prescription pills, for example, which could be bought on the black market. So fentanyl led to the huge surge in opioid and other synthetic opioid related deaths in this country. But as you can see from this graphic from the CDC, again, this is the most recent information from February of 2026, that there has been now recently a reduction in all drug overdose deaths, including from any opioid and synthetic opioids and from commonly prescribed opioids. Sobering statistics over a 24-year period, however, up to 2023, there were 806,000 drug-related deaths related to opioids in this country. That number is now on the decline. Yet and still, about 217 people in this country die every day from an opioid overdose. So we still have to maintain our due diligence, and our prescribing has to be reliable and responsible for our patients who do require opioid therapy. And we're going to go through that. So as you can see from this graphic as well from the CDC, again, the most recent iteration of their statistics from February of 2026, in the year October 2023 until September of 2024, there were 87,000 drug overdose deaths, which shows that 19% reduction from 114,000, which have been fairly stable over a 5-year period before the reduction actually occurred. So are the guidelines from the CDC actually contributing to this reduction in deaths? Well, that remains to be seen. If you look at who's more likely to sustain a drug overdose deaths, it remains males greater than females by a substantial factor. It remains individuals in the 35 to perhaps 50-year age group. And there are some red flag behaviors that we as prescribers and clinicians must take into consideration. Is the patient, for example, a tobacco consumer? Do they have a prior history of legal difficulties related to alcohol or substances, including things like driving under the influence? Is there a family history of substance misuse of controlled prescribed medications or otherwise synthetic or street drugs? All of these factors must be taken into consideration when we consider our patients as candidates for the use of opiates. Drug overdose deaths, you can see that the most represented age group is 35 to 44. Again, males represented by a factor of 2 or 3 to 1 compared to females. And it's not to say that there isn't a substantial proportion of individuals between the ages of 45 and 65, but still, by and large, this is a condition, a disease, a consequence of drug use in the younger population in 35 to 45-year age group. Now, what's going on in these 7 states? Despite there being a reduction in opiate prescribing per 100 persons across the entire country, look at Oklahoma, look at Arkansas, Louisiana, Mississippi, Alabama, Tennessee, and Kentucky. And there are a cluster of states here, all bunched together, where the prescribing dispensing rates is still about 50 or more per 100 persons. Something's going on in the south and the southeast part of the country, which has yet to be reconciled. It seems that the other 43 states have gotten the message, but we've got a problem here between Oklahoma to the west, Kentucky to the north, and Alabama and Louisiana to the south. Something's going on in these 7 states, and the CDC is looking at this and addressing this. If you look at the total opioid overdose deaths, again, this is opioids. This is from the year 2023, which is the last year that the statistics have been collated by the CDC. About 80,000 overdose deaths from opioids. All drug overdoses in that year, 2023, were 105,000. And they have it codified by state. So obviously the states with larger percentage of the population, look at California, about 8,000 opioid deaths. All drug overdose, about 11,000. You can see that the percent of deaths related to opioids of all overdose deaths is somewhere ranging between about 60 and 85%. So opioids do contribute to a majority of overdose deaths throughout the entire country, but do not constitute it in its entirety. We still have to reconcile cocaine, benzodiazepines, alcohol, and other things. If you look at the remainder of the country here, again, you look at the opioid overdose deaths as a percent of all drug overdose deaths. And again, we're somewhere between about 45% to about 91% in New Hampshire. And again, the larger states like Pennsylvania and Texas have a disproportionate percentage both of opioid-related deaths from overdose as well as all drug overdose deaths. But again, the percentage of deaths due to opioids ranges somewhere between about 50% up to about 90%. So we're doing better. Have the guidelines helped us? Well, you might say so. Still, there's a perception in this country that our life expectancy has dropped to its lowest number in the United States in the past quarter century. And there's some consideration that fentanyl and other drug overdose deaths have contributed to this reduction in the expected longevity of Americans. And we have to do better. We went from 78.8% average life expectancy in this country, males and females, down to 76.4. And again, it's considered to be a consequence of the opioid crisis in America. So the CDC guidelines, the first iteration is now 10 years old, hard to believe. And physicians were taken to task if we didn't closely adhere to these guidelines. But these guidelines were basically not intended for pain management physicians. They were intended first and foremost for primary care physicians who treat chronic pain. And it excluded pain due to cancer or end-of-life scenarios or palliative care, or for those individuals below the age of 18. Chronic pain was defined as pain which was persisting for greater than or equal to 3 months in duration. So again, the first iteration of the CDC guidelines, which were considered to be draconian by some and overly punitive, were really only suggestions, and I'm going to go through that in very brief here. The recommendations from the 2016 CDC guidelines were somewhat intuitive and inferential, weren't they? They stated that when opioids are started, clinicians should prescribe the lowest effective dosage. Well, that seems to be something which is just common sense, pure and simple. Again, the number which was relatively bastardized, however, was the increasing dosage beyond 90 morphine milligram equivalents per day. And a lot of people took this as dogma. They became, whereas this was almost arbitrary and capricious information, 90 morphine milligram equivalents began to be weaponized. And there were physicians who were taken to task and sometimes treated punitively if they were prescribing beyond 90 morphine milligram equivalents per day. No longer does that consideration hold true for the 2022 iteration of the CDC guidelines. We're going to go through that. In fact, the CDC admitted, and this was unusual, that the CDC admitted that they had made a mistake, that their data might be erroneous in terms of determining or implicating opioids in overdose deaths. A lot of patients who came into emergency departments with suspected overdose deaths were automatically labeled as being related to opioid overdose, when in point of fact, after post-mortem evaluation and autopsies, it was found that opioids were not contributory, but the CDC did include a lot of those deaths as being related to opioids. They may have overestimated that, and that was good that they did a backtrack on that all the way back in 2018. Well, so why did we have a new iteration about 3 years ago now? November 4th, 2022 actually was the second iteration of the guidelines from the Center for Disease Control for opioid prescribing. They realized that this didn't often fit clinical scenarios. Again, certain agencies, and I happen to, for full disclosure, I'm a member of the Illinois Prescription Drug Monitoring Program. I've been a board member for the last 7 years, and I see a lot of these cases come to our attention. And a lot of people on the board look at the numbers in morphine milligram equivalents, and they shudder to think that some patients are receiving 2 and 3 and 4 and 5 times the 90 morphine milligram equivalents per day. And has this information been unjustly used to criticize physicians, sometimes to implement punitive restrictions upon their prescribing habits? Yes, the answer is yes. And so actually the CDC went back and listened to actual patients. They brought together more than 23 physician specialists to get a better handle on real life scenarios and situations, and finally relied upon peer-reviewed literature before making the second iteration of the guidelines. So the take-home message from the new guidelines from 2022 was that these are just recommendations. They're voluntary. They're not mandatory. If you look at the language here, these are suggestions. These are not mandates handed down by the federal government. And that's why physicians should look at them. They should understand them. They should assimilate them. But you don't have to hold them near and dear to your heart and practice within a strict framework as the 2016 guidelines seem to indicate. These recommendations are voluntary. They're intended to support person-centered care. Special attention should be given to avoid misapplying this clinical practice guideline beyond its intended use. So these were the 5 guiding principles that are underlying the new iteration of the 2022 clinical practice guideline. And there was concern, some policies purportedly drawn from the 2016, the first iteration of the CDC prescribing guidelines, that were notably inconsistent with how patient management actually occurs in the community. And the CDC, to their credit, recognized this, which is one of the fundamental principles underlying the new guidelines from 2022. These are voluntary. They're intended to be flexible. They're intended to support, not supplant, individualized patient-centered care. So the take-home message from the new guidelines is that patient-centered care is at the forefront of the prescribing guidelines. They also appropriately pointed out that primary care physicians prescribe, by and large, almost 40% of all opioid prescriptions. So in 2016, the first iteration was directed at not pain physicians and not surgeons and not neurologists but relatively towards primary care physicians. That is, family medicine doctors, internal medicine doctors, and sometimes psychiatrists who were prescribing opioids for their patients. They recognized that pain medicine clinicians were only about 9% of the prescribers, and that dentists also prescribe at a fairly high rate of 8.6%. Now, they also recognize that pain medicine and pain management physicians have a different level of appreciation. They have a different level of education and experience with managing both acute, subacute, and chronic pain. And therefore, these guidelines were carefully tailored away from pain medicine and pain management physicians. Here you can see from the CDC, pain management specialists were not the focus of this or the prior practice guideline. Pain management specialists have extensive training, often expertise, certifications, and treatment modalities that other clinicians do not necessarily possess. So pain medicine physicians, this is why you see in the community, for those of you who are practicing as I do, a lot of the primary care doctors and the family medicine doctors are shunting their chronic pain patients to our practices because they got the message from the CDC. The CDC said, pain medicine, pain management physicians, you're in a different category or classification. You understand these disease processes. Some of them are somewhat remote, in fact, and not very common, and you manage this as part of your day-to-day practice. Therefore, these guidelines are not necessarily tailored to you. Doesn't mean you shouldn't read them, understand them, and assimilate them. They also wanted to point out, and I think this is very fair, the CDC wanted clinicians to understand that opioids should not be the exclusive modality for managing acute, subacute, and chronic pain. We know that there's very little clinical data to support the long-term ongoing use of opioids in chronicity or in perpetuity. We know that. We know that non-steroidal drugs like acetaminophen, physical modalities, physical therapy, exercise therapy have shown benefits for patients with acute, subacute, and chronic pain. And the CDC wanted to re-emphasize for all clinicians across the board that opioid therapy is maybe similar to other modalities. Keep that at the forefront when initiating or perpetuating therapy for your acute, subacute, and chronic pain patients. Evidence on long-term effectiveness remains very limited. There's very little hard and fast level 1 or level 2 data to substantiate and support the use of opioids respectfully in our practice. Doesn't mean that you will be cited for doing it. In fact, the actual number of clinicians who've been dealt punitive measures across the country each year is only about 18. It's a very low number. I'm going to show you the data published in the journal Pain Physician very recently. It's also recognized by the CDC that it's hard to discontinue opioids for patients who've been chronically consuming them. That can be a challenge. We're not expected to be addictionologists. We're not expected to run a rehabilitation service from our own unique practice. We are expected to understand that alternative and competing modalities do exist, to understand fundamentally that there is no long-term benefit to the use in chronicity for opioids in perpetuity, but that tapering or discontinuing opioids in patients who've taken them for a long period of time can be associated with significant clinical risks. The risk of patients who go through the process of elimination abruptly, that go through an abrupt withdrawal, can have consequences, including elevation of serum cortisol, elevation in the distribution and elimination of catechols, for example, epinephrine, norepinephrine, surges in cardiac toxicity, heart rate elevation, blood pressure elevation, even myocardial infarction can be associated in some cases with abrupt withdrawal, and the CDC recognized that. So the new recommendations, the 2022 November 4th recommendations from the Center for Disease Control, were grouped into 4 areas. Number 1, and this is important, determining whether or not to even initiate opioids for pain. Does your patient have a pain level for which opioids might be considered reasonable and customary in the community? And seriously, of course, you're not going to prescribe opioids for a patient who has a low level of pain, that it can be managed with non-steroidal drugs or acetaminophen or gabapentin, for example. Not for a pain level of 1 to 3 out of 10, which is mild pain. Maybe not for a 4 to 7 out of 10 moderate pain, but maybe to be reserved using the World Health Organization stepladder approach for managing pain, which was first evolved in the 1980s by Vittorio Ventafrida from Italy, and has been a very useful tool for patients who've got 8, 9, or 10 severe levels of of pain: acute, subacute, and chronic. Selecting opioids, determining dosages is individually determined, deciding the duration of the initial opioid prescription, and conducting follow-up. If you initiate treatment with your patient, it's not acceptable, for example, to write a 3-month prescription the first time you meet a patient and have no expectation for assessing the benefits of the use of opioid therapy without looking at the prescription drug monitoring program, without conducting urine toxicology or blood sample toxicology monitoring for your patient. You've got to have a plan in place that is reasonable and respected within the community. Also assessing risk. What are the risk factors? Do you use an opioid risk reduction strategy? And if so, do you document that? Do you document the patient's responsiveness to therapy? Obviously, if the patient comes to your practice and it's a first-time patient and they say, my pain is 10 out of 10 without medication, and it only dips down to 9 over 10 with opioids, well, maybe opioids are not the appropriate therapy for your patient. So documenting, having discussions with your patient, documenting what those discussions entail, all part and parcel to the new guidelines. Non-opioid therapies are at least as effective as opioids, and we know that, both for acute pain as well as subacute and chronic pain. And so clinicians are encouraged to maximize the use of non-pharmacological therapy, physical therapy, occupational therapy, at-home exercises, weight reduction, smoking elimination, other things that can be useful adjuncts to managing chronic or acute and subacute pain. Non-opioid pharmacological therapies, we've touched on that in brief. Non-steroidal drugs pretty much have the same efficacy across the board for acute, subacute, and chronic pain. We know that. Implementing them, we should discuss with the patients what the benefits and risks of opioid therapy are. All opioids, for example, engender 6 potential side effects: nausea, vomiting, itching, urinary retention, constipation, and of course the dreaded possibility of respiratory depression. All patients for whom opioids are initiated should be educated about the use of naloxone or naltrexone, but pretty much naloxone nasal spray. It is my custom and practice, when both initiating as well as perpetuating opioid therapies in my practice, to prescribe concomitantly Narcan therapy for all patients, and we'll discuss that as well. The second recommendation in the new iteration of the CDC guidelines was that non-opioid therapies were preferred. We talked about that. Clinicians should maximize to the extent possible. Of course, if a patient's got a bleeding ulcer, NSAIDs are not an appropriate choice, because NSAIDs by themselves engender 6 known side effects or consequences. This was published on April 6th of 2005 by the CDC. All NSAIDs can cause to the GI system perforation, obstruction, or bleeding, or to the cardiovascular system thrombosis, myocardial infarction, stroke. When you use NSAIDs, you must get an informed consent from your patient. We should work with our patients to establish treatment goals of pain and functionality. Again, if you're not documenting an improvement in functionality for your patients when they are using opioids, probably opioids should not be perpetuated for that patient. If the patient says, my pain doesn't change with or without these medications, I'm not more functional on these medications, perhaps these are not the appropriate medications for your patient. When initiating therapy, again, for acute, defined as a pain less than 3 months in duration, subacute 3 to 6 months, or chronic pain longer than 3 months, clinicians should prescribe immediate release opioids. So avoid the use of extended duration opioids for any of these contingencies. Although in my practice, I'm using a lot of extended duration Schedule 3 medications like buprenorphine, Butrans patch. Why do I do that? Because it avoids the peaks and the troughs, that sine wave, that roller coaster in serum concentrations and hence central nervous system concentrations of opioids for chronic use. I'm a big proponent of the use of buprenorphine. Recently, I had one of the state oversight agencies sent me a list of my prescribing. I'm prescribing in the upper 5% throughout the entire state of Illinois here. Butrans and buprenorphine products. We're going to talk about them a little bit later on in this discussion. And I'm a firm proponent in the use of drugs which are partial mu agonists and kappa receptor antagonists. And we're going to talk about how that can benefit your patients. Again, the recommendations from the CDC: prescribe the lowest effective dose. I mean, this is intuitive and inferential. When meeting a patient for the first time, obviously you've got to take into consideration, have they been a legacy patient? from another practitioner? Why are they coming to see you? Were they discharged from their prior practice because of aberrant behavior? Did they fail one or several drug urine toxicology monitoring tests? Why are they now your patient? Does the patient require opioids? Have they failed competing and alternative strategies, including physical modalities, including the use of nonsteroidals and acetaminophen, and the drugs that block the alpha-2 delta receptor of the voltage-gated calcium channel, like pregabalin, like gabapentin? Have they done membrane stabilizing drugs? Have they used local anesthetics like the World Health Organization stepladder approach for managing pain would suggest is important? Prescribe the lowest effective dose. This is intuitive and inferential. Clinicians should optimize other therapies and work closely with patients to gradually taper or lower dosages if warranted. Remember, we don't want to abruptly cease and desist prescribing for patients who've been dependent upon opioids. We're not going to talk about that as an addiction. We're talking about a physical dependence, meaning that they will have a withdrawal reaction if opioids are abruptly discontinued. Do you have a strategy in place for the use of drugs like clonidine, which block the sympathetic nervous system discharge, which is attendant to the abrupt discontinuation of opioids? Do you know how to manage drugs like clonidine, transcutaneous or oral clonidine, for example, for your patients to minimize the dreaded consequences of the withdrawal reaction, which, while not universally harmful, can cause some significant consequences for your patient? Remember, there's only withdrawal from a couple of things which can be very harmful and lead to death. Benzodiazepines, for example, barbiturates, and alcohol. Those are the three chemicals which should not be abruptly withdrawn because they can lead to seizures and death. Again, barbiturates, benzodiazepines, and alcohol must not be abruptly withdrawn from patients. Opioid reduction will not typically lead to death. It may be exceedingly unpleasant for patients, but keep that in mind. Abrupt cessation of opioid use, while not recommended, does not typically lead to death. Clinicians should optimize other therapies, use the lowest doses when initiating and perpetuating medications. Do not prescribe greater than quantity than needed for the expected duration of pain. Again, I want you to read the language of this recommendation. It's the same language in all the recommendations. The word should appears. So these are not mandates. The CDC guidelines are suggestions which are intended to help you to perform better when managing patients' acute, subacute, and chronic pain. The word should appears in every recommendation. If you look back here, clinicians should carefully weigh benefits and risks. Clinicians should prescribe no greater than quantity than needed. I need you to understand how fundamentally important the word should is. It doesn't compel you to follow this. In a court of law, this is not a mandate. This guideline is a suggestion about how to best manage your patients, but you can't be held accountable to not strictly adhering to the language. The language is very specifically written. It's been carefully considered by legal teams of experts. The word should appears everywhere. Here, recommendation 7, clinicians should evaluate the benefits and risks within the first 1 to 4 weeks. Doesn't mean you have to do that, but it is a best practice approach to see your patients within a month of starting and initiating therapy. Assess whether opioid therapy has been beneficial for their pain. Assess whether there have been any side effects. Document the benefits of opioid therapy. Document any potential consequences or side effects. Document the improvement in functionality, both at home and in the workplace, if that's applicable. Again, should regularly reevaluate. Notice the language in these guidelines, folks. This is very important. This is not a mandate. This does not tie your hands. This does not beat you over the head with a stick if you don't adhere word by word, line by line to the guidelines. They were very specific in the 6-year interval between 2016 and 2022 to make these guidelines more user-friendly, and the word should appears in every single guideline. Here again, recommendation 8, before starting and periodically, clinicians should evaluate risk. Again, it doesn't say you must. It doesn't say you go to jail, do not pass go, do not collect $200 if you don't do that. It said you should evaluate the risk. You should consider a plan to mitigate risk, including offering naloxone. Now, in my practice, and again, I'm speaking from personal experience, not as a board member for the Illinois Prescription Drug Monitoring Program. This is my own practice. I prescribe Narcan nasal spray for all patients when initiating opioid therapy and when perpetuating, or with legacy patients. I make sure that they have it. I make sure that I educate them on how to perform the nasal spray. I have a dummy prototype in my office, which looks exactly like the nasal spray that comes from the pharmacy. I show patients how to do it, even though it would appear as simple as giving yourself a saline flush, which it really is. I do educate all my patients on how to use naloxone. And again, this is not a mandate from the CDC. It's a recommendation. So understand that. Recommendation 9, again, the language says clinicians should review the history of controlled substance using the prescription drug monitoring program. I'm a huge proponent of that. Virtually every state of the country, including Puerto Rico and including Hawaii, has a prescription drug monitoring program. There's a lot of cross communication between and among the states, which is fantastic. I've got patients who come to me from the north, from Wisconsin. They come to me from the east, from Indiana. They come to me from Ohio. They come to me from Missouri, for example. And it's good that the states communicate one with the other in many instances. Looking at the prescription drug monitoring program, again, is not a mandate. The language is very specific. It said you should review it. And you should do this on a visit by visit basis. Now, it's probably very important to see patients at least every 90 days if you're delivering Schedule II medications. It's my practice that no more than 2 months in almost every circumstance, not exclusive to 90 days. I see almost all patients within a 60-day window. I assess their functionality. I assess their response to therapy. I assess and document any side effects, and I assure that they have access to naloxone. I also look at the prescription drug monitoring program to assure that they're not receiving alternative prescriptions from other clinicians. Because in my opioid assessment, which is a contract between myself and the patient, that's a trigger for automatic discharge. And I do this on a regularly and routine basis with some rare exceptions. What are those exceptions? Well, a patient has a major orthopedic surgery. They're not able to get back into my office because they're laid up with rehab in their home, for example, and the orthopedic surgeon gives them a very small aliquot, 15 tablets of Percocet under rare occasions, because the patient can't get to me and I don't electronically submit their next month's prescription. I have given some latitude or leeway in certain circumstances, but by and large, if I see that a patient is receiving prescriptions from a secondary source, it's a trigger for discharge, the same way that a failed toxicology test is. Now here, again, recommendation number 10, look at the language. Clinicians should consider the benefit. It doesn't say you must. It doesn't say you have to do quarterly or every 6 months urine toxicology studies. In my practice, again, I do quarterly, at least quarterly, random supervised urine toxicology monitoring studies for my patients. I think that that's a best practice. And I make clinical decisions based upon what I find. Do I discharge patients? I discharge patients all the time. Somebody tests positive for cocaine. It's not a 3-strike policy, folks. This isn't baseball where you get to stand at the plate and take 3 swings and you miss twice, and the third time you're struck out. In my practice, it's 1 strike and you're done. And all the patients know that. I'm totally transparent when initiating therapy and perpetuating therapy. I look at toxicology testing. I look at patients smoking marijuana. Now, there are federal legislation and state legislations that mandate how people practice with marijuana. I'm not going to tell you whether marijuana is a trigger for discharge. It obviously varies by your interpretation of federal laws as well as state laws regarding the use of recreational or medical marijuana, which can be utilized in some cases for chronic pain, although the jury's out as to the specificity of medical marijuana for the benefits of patients. Recommendation 11, clinicians should use caution. Again, it doesn't say must use. It doesn't put you in jail if your patient's taking a benzodiazepine concurrently with an opioid, but it says pay attention, folks. And I think this is, again, best practice. If your patient's consuming Xanax, I think Xanax is the most addicting chemical ever created, more addicting than heroin, in my opinion. I would have great consideration and concerns and caution about initiating or perpetuating opioid therapy on Xanax, particularly. Diazepam, clonazepam, these are also benzodiazepines. They are co-analgesics. And most importantly, they can contribute to respiratory depression in your patients. Remember, opioids do 6 things unique of themselves. They cause nausea, vomiting, itching, urinary retention, constipation, and respiratory depression. Obviously, the trouble for clinicians and patients, of course, is respiratory depression. No one's going to die if they get a little bit of nausea. No one's going to die if they have a little bit of itching. But if they get into respiratory depression, if they don't have naloxone administered in a timely fashion to reverse the deleterious respiratory depression, that patient can die. And that can trigger a whole host of initiation of things against yourself as the clinician. Recommendation 12, clinicians should offer or arrange treatment to treat patients with an opioid use disorder. It doesn't say you must. It doesn't say you must send your patient who you suspect has a drug addiction. Let's call it what it is, folks. We use things like substance use disorder. The language has gotten very fancy because all the drug addicts were up in arms about being called an addict, and they wanted to be known as substance users. Well, they're addicts first and foremost. Just because you change the painting doesn't mean that the apple still isn't red. We know what these patients are. You have to identify them from a behavioral perspective. You have to use things like opioid risk tools, and we're going to talk about that. Again, these are recommendations. The language is specific. The word should appears in every one of these recommendations. Have these new guidelines, or have the first guidelines from 2016, have they worked? Well, the answer is yes and no. We've already seen about a 19% reduction in drug overdose deaths in the country, according to the February 1st, 2026 data from the CDC. The most recent data that any of you will see is what I've just published here in this talk. Here's from the Orthopedic Journal of Bone and Joint Surgery from 2020, showed that there was a 38% reduction in post-surgical opioid prescribing by orthopedic surgeons. Orthopedic surgeons got spooked by the first iteration in 2016 of the CDC guidelines, and they reduced the amount of opioids they were prescribing to their patients. In point of fact, I work with a lot of orthopedic colleagues. They almost always routinely send their post-surgical patients to me for management because they don't want to be on the hook for this. They don't want to be cited. They don't want to be subject to any punitive remedies related to opioid prescribing. I get a ton of patients who've had orthopedic joint replacement or even not joint replacement surgery sent to me for their post-operative pain management. This is becoming much more the norm across the country. Neurosurgeons as well. For elective spine surgery, this is another recent publication from 2021 in the journal Neurosurgery, showed, again, a 24% reduction in prescribing from neurosurgeons. And a large survey of patients, 1,193 patients who were identified. Patients had cervical spine surgery, they had lumbar spine surgery. The neurosurgeons also have reduced routinely prescribing opioids for managing their patients with post-surgical pain. Is there legislation? Will it vary state by state? I really have to give a lot of credit to Florida. Florida has seen a drastic reduction. Florida and Ohio, of course, were notorious for being at the center for the opioid epidemic in the early 2000s, even from 2010 to 2020. Florida's done an amazing thing. They educate their physicians. They make sure physicians understand definitions, acute pain, the normal predicted physiological time-limited response to an adverse chemical, thermal, mechanical stimulus. They want surgeons, they want clinicians, they want family medicine doctors, they want pain doctors to understand definitions. They want prescribers to understand that there's a difference between benign pain and malignancy-related pain, or terminal conditions for which opioid therapy may be responsible. Chronic non-malignant pain. So if you practice in Florida, you've got to take a test. You've got to understand this. You've got to have CME, and other states are slowly following the lead set by Governor DeSantis and his people down there for educating the clinicians about opioid. It's now mandatory in the states where I'm licensed, in New York and Illinois, to undergo opioid training. Now, I told you earlier, clinicians are very frightened by opioid prescribing. We're always concerned about Big Brother watching us, aren't we? And in point of fact, though, you can see from this publication, which came out of the journal Pain Physician about 6 years ago now, that there's not a lot of physicians who are actually being punished in terms of having licensing issues related to prescribing of opioids. In fact, in the years between 2004 and 2017, there are only about 18 prosecutions per year. That's not a ton, folks. when you think about the thousands and thousands of physicians who prescribe each year and the millions and millions of prescriptions that are being written. So who's more likely to be prosecuted? Well, interestingly, osteopathic physicians over allopathic physicians for some reason are more targeted. Being in private practice, those individuals versus being in a university setting are more likely to be cited. Not having your board certification, well, I think that's a big one. I think it behooves you, if you're going to practice in any branch of medicine, to seek and attain your board certification status at the earliest convenience. Obviously, if you're in possession with intent to distribute, and that's not a lot of cases related to that, but yes, there are bad doctors, and we know that. There are doctors who sell opioids for sex, and I've actually served as an expert witness in this state and other states in the prosecution of physicians who've traded opioid prescriptions with patients for other favors, for cash payments. The things that doctors do when they fall off the wagon, and the behaviors are just phenomenal. And so yes, if you're going to distribute, you're going to go to jail. Higher rates of DEA action for foreign medical graduates compared to those who've trained in the United States. I don't know why statistically that occurs, but that's true. So have the legislation and the guidelines worked? We've already talked about nationwide a 20% reduction in all drug-related deaths in 2024, 2025 compared to previous years. Going back to 2017, the first year that clinicians were compelled to read and understand the CDC guidelines, there were 23.3 fewer billion fewer morphine milligram equivalent prescription delivered by clinicians, which represented a 10.2% reduction in prescribing. And so, yes, the first iteration, while somewhat draconian and somewhat punitive in the language, did work. And there's an economic burden, of course, to opioid use disorder and to the fatalities. Opioid use disorder in the United States is a $1.02 trillion consequence. Excuse me. We know that the cost for opioid use disorder and for fatal overdose is phenomenal in terms of what it does to the workforce, what it does in terms of filling up hospital emergency departments and filling up psychiatric departments. It's a $1.02 trillion industry per year. Drug monitoring, even though there are suggestions and the language in the CDC iteration says clinicians should avail themselves of prescription of the urine drug toxicology, in point of fact, studies going back to 2021 only showed that about 50% of patients receiving opioids were ever subject to urine drug monitoring. I think this is now changing. The pendulum is swinging towards more and more patients, but the most recent data still suggests that only about 60 to 65% of patients are ever availed of the use of urine drug monitoring. It's my strong recommendation that if you're prescribing opioids to patients, in addition to your opioid agreement / contract, you should, I won't use the word must, you should make sure patients have access to Narcan. It should be regularly and routinely prescribed by yourself to your patients, and you should, again, I avoid the use of the term must, you should subject them to some form of toxicology monitoring. Urine is the simplest. It has to be something which is supervised. There are many individuals who've used the Whizzinator or they've used their kids' urine. I can tell you stories for hours about patients who've subverted urine drug toxicology monitoring. One of the saddest cases was a patient I had about 15 years ago who was taking his 9-year-old daughter's urine, freezing it, and then when he would go to his, not to my office, but to a colleague's office and have to give a urine drug test, he would microwave his 9-year-old daughter's urine, and he would go into the bathroom and pour from a cup the 9-year-old daughter's urine into the toxicology cup, and he was always passing every drug test. One day, the 9-year-old daughter tells the mother, "Mommy, why is Daddy making me pee into a cup?" Well, that led to the dissolution not only of his pain care, but to the dissolution of his marriage. So there's a lot of things people do to subvert the process, which is why the most effective way to monitor patients with urine toxicology is under direct supervision, and we'll talk about that later. The hidden cost of the opioid epidemic, again, you can see that there were more than 2 million urine drug samples which were sent in the 4-year period from 2016 to 2020. Insurance companies got tired of paying exorbitant fares, almost being held hostage by these urine toxicology companies. And I have a lot of friends who do this business. I'm not being hypercritical, but for some of these tests which cost pennies or dollars to run with a dipstick, whether it's quantitative or qualitative, some of these tests were running in the thousands of dollar range. And insurance companies said, enough. Medicare said enough. And so there's been a reduction of about 70% in the reimbursement for these companies. A lot of these companies have gone belly up, but urine toxicology monitoring is a huge business in the United States. We'll go through a few definitions, and then we'll talk about buprenorphine and its various formulations, because I'm a big proponent in the use of buprenorphine. You must understand that not all your patients with pain, some of them have dual diagnoses, for example, and no one expects, if you're not a trained psychiatrist, to understand in its entirety what that entails. But you must understand that some individuals will use opioids for chemical coping. You must understand that they use drugs to manage stress, sleep disorders, bad relationships. You must employ, you should, I'll use the language should because that's what the CDC uses, you should employ an opioid risk strategy program. That includes things like ORT, opioid risk tool, or the screener and opioid assessment for patients with pain, SOAP, or DIAR. You must understand how these tools are administered. Some of them are free on the internet. Some of them you pay a subscription for. I would seek out the free opioid risk reduction tools, the surveys that you can administer in your office to your patient at the initiation of therapy and periodically throughout the duration of their therapy. This is something which is very simple to administer, administered prior to the initiation of opioid therapy. It's called the opioid risk tool. Patients are stratified as low risk, moderate risk, or high risk. Screener and opioid assessment for patients with pain, also known as SOAP, self-administered in the waiting room. These are easy questionnaires. These are check boxes to determine what a given patient, what a unique patient's risk stratification ought to be. What about the molecule? I've talked about buprenorphine now. I've mentioned it. I have a great history with the use of buprenorphine. I was privileged in the 1980s to work with Professor Alan Winnie, who was one of the fathers of the American Society of Regional Anesthesia and Pain Medicine. We used intramuscular buprenorphine and buprenorphine added to local anesthetics to prolong the benefit of brachial plexus block and lower extremity block. So I've got a 40-year history with this molecule. I think this is a fantastic and under-prescribed drug, which can save you, the prescriber, a lot of headache and a lot of heartache. It's an antagonist at the kappa receptor. We talked about that. It's a partial agonist at the mu receptor. It's very tightly bound to the mu receptor. The problem with buprenorphine is that if you take a group of recovering drug addicts, heroin addicts, and you subject them like the Pepsi taste challenge or the Coca-Cola blind taste test, and you say, what do you like best, the Pepsi or the Coke or the RC Cola, and they can give you a rating. Well, drug addicts in recovery, meaning that they've had a substantial history of exposure to mu agonists, will not rate buprenorphine favorably. They don't get high from buprenorphine. That is why it is a Schedule III drug, which saves you a lot of headache as well. You can also give, in certain circumstances, refills of buprenorphine. It has a high affinity for binding for the mu receptor. It is a potent analgesic. It slowly dissociates from the receptor. Again, in addicts will not select this over oxycodone or hydromorphone or fentanyl or hydrocodone. They're not going to say, give me this to the exclusion of other drugs, because it doesn't tweak the pleasure center in the central nervous system the same way. There's little good effect with subjects who are moderate, who I've shown moderate to modest interest in the product. They don't get high from this drug, but from a pure perspective of managing pain, this is a very valuable adjunct. And it comes in 3 basic formulations for pain. There are more. We're not talking about treating addiction. I'm not an addictionologist. I don't use much, if any, Subutex or Suboxone. Although that's within the purview of how I practice. Buprenex, I told you about. It's injectable buprenorphine. I conducted some of the only studies in the world on injecting Buprenex in addition to local anesthetics, which we found drastically improve the performance of local anesthetics for things like brachial plexus block, lower extremity sciatic nerve block. But Butrans patch has been around now for more than 15 years. This is a fantastic adjunct to you. It comes in various formulations, 5, 10, 15, 20. I would recommend not starting out in less than the 10 microgram per hour patch. I think 5 is basically a placebo, but somewhere between 10, 15, and 20. The beauty of this, it's a 7-day patch. The patient puts it on an area. It doesn't matter where their pain is. They can have low back pain, and they can put the patch under their armpit or under their breast or behind their knee. They don't have to specify the application of the patch to their pain. A great adjunct, which I have found to be very useful as an oral sparing remedy or adjunct to my patients. Belbuca, another great preparation, been around for 10 years now. And again, these drugs are indicated not for opioid naive patients, but for patients with moderate to severe chronic pain. Now, what does that mean? Again, pain that has a duration of longevity of greater than 6 months. Some studies would say 3, that has a pain score of at least 4 to 7 out of 10, up to 10 to 10 on a numeric rating scale. I use this in as many patients as I can get to have it approved. Insurance still remains a stumbling block, and I don't know why. I don't know why insurance would resist the use of either Belbuca or Butrans, because these have been demonstrated and documented in peer-reviewed literature to A, have an opioid-sparing effect, and to B, have a ceiling on respiratory depression, and C, to be very effective as analgesics. Partial mu receptor agonist, again, there's a reduction in the abuse potential when we use buprenorphine products. There's a low risk of physical dependency or analgesic tolerance. It's a Schedule III drug. As Schedule III drugs, unlike Schedule II drugs, fentanyl, morphine, oxycodone, hydrocodone, this drug has less abuse potential. Keep that into consideration. It's a wonderful adjunct to your practice. I consider using it in the vast majority of my patients when applicable, when I can get insurance approval. Now, when you're treating chronic pain or acute pain or subacute pain, you have somewhat of a duty. Again, you should, not must, the language is very particular. You should consider substance use disorders in your patients. And how do we do that? Well, you look for things in the patient's medical record. You take a history. I always ask patients, are you being treated by a psychologist or a psychiatrist or a clinical social worker? Have you ever been in treatment for a psychiatric disorder? Part of my questionnaire, have you ever been treated for alcohol or substance use? Has any member of your family ever been treated for alcohol or substance use? Have you been the victim of sexual abuse or molestation? These are tough questions to ask, ladies and gentlemen, but you have to ask them. Are you a consumer of tobacco products? Because we know there's a very high correlate between tobacco consumption and tobacco misuse and substance use disorder. Bipolar disorder, very highly represented in patients with substance use disorder. Cocaine dependence, ethanol dependence, these are all questions that I ask my patients. The prevalence of depression is about 8%. I think it's much higher, but this is from the psychiatric literature of 36,459 patients who were receiving opioid therapy for chronic pain, and 8% were depressed. I think the number is between 15 and 40%, but this is from the psychiatric literature. Attention deficit and hyperactivity deficit disorder and substance use disorders, a very high correlation between patients with ADHD and substance use disorder. More than 50% of patients with adult ADHD will have substance use disorder. Interestingly, those individuals who are treated with stimulants, I know Adderall use and drugs which are hyperstimulants, there's some controversy to using them with adolescents. But interestingly enough, adolescents and adults who are treated with stimulants show a reduction in substance use disorder later in life when they are exposed to opiate use. Axis 2 disorders, substance use disorders. Again, antisocial personality, very hard to make a clear-cut diagnosis. We're pain physicians, or maybe we're family medicine doctors, or maybe we're internal medicine doctors. It's not always cut and dry, but if you identify somebody who's been incarcerated, for example, with antisocial personality disorder or a borderline personality disorder, very high correlation between those conditions, respectfully, of course, and substance use disorder. Anxiety disorder, again, anxiety is not a crime. Anxiety, a lot of people have anxiety disorders, but up to 24% of individuals with anxiety disorders will be highly represented in substance use disorder population. Post-traumatic stress disorder, we see this not just in the military population, we see this from victims of sexual abuse or domestic abuse. We see this in commonalities throughout our clinical practices. I've got patients who've been the victims of horrible violence. I have a patient who was shot multiple times when she was working in a grocery store and left for dead. She was shot 7 times and she survived. 3 of her coworkers were not so fortunate, and she's a patient of mine with chronic pain. And again, she has post-traumatic stress disorder. High representation of substance use problems in patients with post-traumatic stress disorder. Again, PTSD is not a crime. It's very resistant to treatment, however, and you must factor that into your decision-making and consideration when you treat these individuals. Schizophrenics, high percentage of schizophrenics will have substance use disorder, and that extends beyond opiates to drugs like alcohol, drugs like cocaine, or even marijuana. Approximately 80% of schizophrenics are nicotine dependent. Again, the correlation is unmistakable and undeniable between tobacco consumers and opioid use disorder. I strongly counsel and send my patients for tobacco cessation programs if they're chronic pain patients who are seeking to use opiates. I'm not always universally successful in eliminating tobacco use, but it's a mandate in my practice to assess them. So finally, what are my recommendations? I've been speaking now for a long time. I think it's very important, and I will use, along with the CDC, the word should and not must, because I think that mandating anything is a very slippery slope, and that leads to a lot of individuals unnecessarily being targeted by oversight agencies and by punitive agencies. I think you should have the patient in a prescription drug monitoring program assessment. I do this for all of my patients at the initiation of therapy and at each and every visit. So my staff has been trained to query the database every time a patient comes in to my practice, each and every visit. It's not sufficient, in my opinion, to do it one time at the initiation of therapy or do it every 6 months. I do it at every visit. If I catch somebody, I ask them point blank, why did you get opiates from your dentist, Dr. Jones, when you have a signed agreement with me stipulating what the consequences of that are? And I pretty much discharge everybody. I have a one-strike policy. If you break the rules, you're done. I don't have a duty or an obligation to do anything for you in terms of prescribing. I will give you a 1-month prescription refill, and I will give you the list of 4 or 5 pain clinics in the immediacy of where I practice to go seek out their care and treatment, but I will not prescribe beyond this prescription. Urine drug toxicology, the same thing. They break the rules, I will have a discussion. Miss Jones, Mr. Jones, I see that you're using marijuana. What are the purposes of that? Where are you obtaining this legally, through a vendor, or illegally? And then I'll have a discussion and education. Cocaine is an automatic discharge in my practice. No opioids at the first visit. And I'm going to tell you a little story about that in a second, which is very sad, but about no opioids at the first visit. But it's my rule that when I meet somebody, I need to investigate who these people are. Remember, opioid prescribing is not compulsory. It's part of an overall treatment paradigm or protocol for how to manage acute, subacute, or chronic pain. There is no medical condition which demands the use of opioids except in the perioperative period. So I want to be specific about that. No benzodiazepines. Well, we have some patients who are legacy patients. I will educate them. I will tell them, especially with alprazolam. I think Xanax is a horrible medication, should never have been created. The amount of what it does to dopamine levels, what it does at the pleasure center of the brain is profound. If somebody uses a little bit of clonazepam or short dose of diazepam for its muscle relaxant properties, that's one thing. There are other drugs which can be used for anxiety, which are superior to the benzodiazepines. Very deleterious to your practice to have patients who are co-consuming benzos and opioids. Screen your patients ahead of time. What does that mean? Well, I'll get a referral from a colleague or from some unknown physician in the community. I want to know, why are you sending me that patient? Are you dumping that patient on me because you no longer have a comfort level with that patient? Has the patient violated prior opioid agreements with prior practitioners? Has that patient failed drug tests with the other practitioner? I want to query the database before I see any patient. I don't automatically accept and embrace all patients coming to me. I've got a very busy practice. I don't have to do that, and neither do you have to do that. Use an expectation of care agreement. Again, that's considered a contract. Is it legally binding? Well, you can make it legally binding. The agreement stipulates what the expectations are on behalf of the patient and what the expectations are on the behalf of the prescriber practitioner and the practice itself, the nurses, the the SAs, the MAs, the people in your immediacy. Again, 90 morphine milligram equivalents, that was in the 2016 iteration of the guidelines. It's no longer standard of care practice, but it's useful to look at. Why does your patient need more than 90 morphine milligram equivalents? And I will tell you this, there are some studies in the peer-reviewed literature that do show that the incidence of consequences, negative consequences from opioids increases as the MME increases. I have almost, not all, but almost no patients in my practice who exceed 90 morphine milligram equivalents. Get yourself an opioid calculator, a conversion calculator. Learn to transition between different classes of opioid medications and use this in your practice on a regular basis. Ask about withdrawal. See if your patient's withdrawing. Ask about constipation. A lot of your patients won't tell you, hey, doc, I haven't had a bowel movement in 7 days, but because they don't want to lose those opioids. You must ask about it. Use adjuncts. Use drugs like Movantik if the patient has opioid-induced constipation. But you must assess the patient for nausea, vomiting, itching, urinary retention, constipation, respiratory depression. You must query your patient, inquire to your patient and to their care providers if they come attended. Educate the patient, ask about alcohol, drug storage, make sure that the patient doesn't say, well, my neighbor came over to borrow a cup of flour, and next thing I know, my 90 Norco tablets were missing. Well, guess what, buddy? Or guess what, ma'am? That's on you. With very rare exception, I had a case just yesterday. A lady was on a bus. Her purse was stolen off the bus. It had her medication in it. She had recently refilled it. She called the police. She filed a police report. I have the police report in my possession. It's part of her permanent medical record. I may make certain adjustments to giving somebody like that a second chance, but I don't give second chances on Friday at 6 o'clock when the clinic is empty and the patient says, I suddenly ran out of my medication. I'm not going to be having any opioids for the weekend. Please give me an emergency refill. I don't fall for any of that garbage, and neither should you. People who lost their prescriptions, people who don't safeguard their medications, it's incumbent upon the patient to safeguard their medications. Again, the exception being that lady on the bus who had her purse stolen, who had eyewitnesses, who had a police report. I have the police report. I documented that. And again, remember the use of drugs like buprenorphine, tapentadol, hard to get now. Avoid methadone. Methadone is not good. Now, I talked to you about prescribing on the first visit. This is a tragic story about a wonderful doctor, no longer with us, deceased as of 2017. Todd Graham was practicing in my neighboring state of Indiana. He was practicing in a large orthopedic group. He was the pain doctor that managed the patients. He was referred a patient who came in for the first visit with her husband, a woman in her 50s. She said, I need you to give me oxycodone. I have chronic non-malignant pain. Dr. Graham did what I would have done. I have to check your records. I've got to check the prescription drug monitoring program. I've got to go back and look at the prior notes before I can consider initiating opioid therapy with you. Well, the husband was irate. He said, my wife's going to have a withdrawal. Dr. Graham said, listen, I'm going to do my best. I'm going to make this assessment in a timely fashion. I'm going to try to help your wife as soon as I get all the information and data. The husband would not stand for it. He said, this is not acceptable. My wife needs these narcotics. And Dr. Graham said, I'm sorry, this is my protocol for managing new patients. Dr. Graham went out at lunchtime to his vehicle. The husband was waiting in the parking lot, and he shot Dr. Graham and killed Dr. Graham. This is obviously an outlier, but protect yourselves. Know about your patients. Call security when you have hostile patients. Call law enforcement when you have threatening patients. This is what I do in my own unique practice. Exit strategies. Discharge patients who are outliers. Look for patients who are abusing or misusing the medications. Make your assessment of things like addiction. Look for the rare phenomenon, but well documented in laboratory animals, of opioid-induced hyperalgesia. What is it in a nutshell? You give your patient a pain medicine, an opioid, a controlled substance, and they get worse rather than get better. Does that mean that they're faking? Does that mean that they're drug seeking? Not necessarily. In many cases, yes, it does. There can be the phenomenon of opioid-induced hyperalgesia. Please look it up. Please look at the great studies by Sanford Silverman and others who've written extensively about opioid-induced hyperalgesia. Treat side effects to the extent possible. Understand the 6 side effects of all opioids: nausea, vomiting, itching, urinary retention, constipation, and of course, respiratory depression. Document everything. Documentation may save your practice and may save the patient's life. Send the patient for behavioral counseling when indicated. Medically supervised withdrawal. I'm not an addictionologist, but I do know how to use clonidine. I do know how to use buprenorphine products to help reduce the patient's reliance upon opioids. Adjuvants for pain. Remember, opioids are not the first line except in the immediacy, in the perioperative period, or in the acute traumatic sense when you've got a patient who's been the victim of a motor vehicle accident or some other catastrophic event. And I know there are a lot of questions. You can contact me. My email is available through the Society of Pain Practice Management. I would love to engage you in a dialogue or conversation about these strategies. My email address is kdcandido1@gmail.com. I thank you for your time and attention today. It's been a privilege to work on behalf of SPPM to try to expand your knowledge on these topics. Have a great rest of your week and be safe.